And welcome to the Benefit Whisperer podcast, hosted by Ralph Weber. Ralph, it's good to be with you again. For those who are following along, this is episode number 2 of the Benefit Whisperer. The first episode, some pretty dramatic stuff we covered in that first episode in terms of things early in your life, healthcare issues that shaped you and had an impact on what you do and why, in fact, you do it. And just for those of you who have not listened to it, I would encourage you after you listen to this episode to go back and listen to it, as a matter of fact. So, Ralph, it's good to be with you again, my friend. Today, we're going to look at the impact of what you do and the kind of advocacy that you practice and that kind of drives you, if you will. But let's start by saying hi. Hello,
Hi,
Ralph.
Good to see you again.
As always. Good to see you as well.
Yeah.
It's good to see you as well. So I'm not kidding. The first episode is really compelling. And it contains the reasons why you do what you do today. And what I want to do in this episode is I want to get into you talking about the most rewarding aspect of what you do, which is helping employers provide affordable health care for their employees. So why don't we begin there? What is the most rewarding aspect, Ralph?
You know, Bill, there's a lot of reward in what I do, and it's not always apparent. And sometimes it seems the exact opposite. As I was telling you last episode, when Dr. Bernard's patients would come back, instead of saying, thank you for restoring my heart, giving me a new heart and extending my life, they were angry. And some employees initially are, well, this is a great health plan, but I can't afford it. The deductible is too high. Okay. So we do certain things. And when I can save a family from bankruptcy, get something for an employer that they can afford, reduce their costs. Most of my clients, we reduce their costs sometimes every single year, lower than the year before because of all the waste. There's so much waste, Bill, in healthcare and so much that we can do about it. A lot of people do what I do. I'm not the only one. But last episode, I told you why I do it, the passion, the healthcare, the mental health, the finance, things that have shaped my life. And that's why I get out of bed. I get out of bed, Bill, because these things have happened to me and they could happen to somebody else. And if they do, I want to be there to help them, preferably beforehand, so that it's not as impactful and it's not as hard to deal with as it was for me.
Well, this came up in the last episode as well, and you just referenced it when you were talking about Dr. Bernard, and that is the impact of rising medical debt.
Yes.
And what we can do to address it. As anyone who knows anything about the American healthcare system knows, medical debt is a very serious issue. And in fact, it is the number one cause for personal bankruptcies.
Absolutely.
In America. So what are your thoughts on this rising debt crisis?
Well, 2/3 of all bankruptcies are due to medical reasons. That's the first thing. And that's very, very significant. And most of the people that declare bankruptcy have insurance. It's not that they're bankrupt because they didn't have insurance. They didn't have coverage. That was not the case. They went bankrupt even with insurance. Okay. The deductibles and out-of-pocket costs are rising every year. The cost to employers are rising every year. This year, 2025, it's going to cost almost $16,000 per employee for an employer to insure their people. So if you have 100 people, that's $1.6 million. Most of my clients are under $10,000 per person. A lot of them are, 6, 7, 8,000. So if you have 100 employees, you could be as low as 650, 700, 800, 900,000. Most of my clients, maybe they don't start there, but they end up under 10,000, which is still a lot, but it's better than the alternative. The average family premium now is $24,000 a year. Wow. And then on top of it, the average deductible and out-of-pocket costs for a family can be easily $12,000. So we're talking $36,000, $3,000 a month for a family. to have insurance, the premiums, the out-of-pocket cost to use the insurance. That's a lot of money, Bill.
That's a lot of money. That is a lot of money. I mean, what can be done to address that? What do we need to do here, Ralph? Wow.
Well, I mean, there are a lot of lawsuits out there right now against insurance companies, against employers for not having a cost-effective health plan. And you can have a cost-effective health plan. There are millions of ways to do it. I've analyzed health plans. I've analyzed all kinds of health plans. It starts with looking at the contract, reading the actual contract between the employer and the insurance administrator. What does it allow the insurance administrator to do? Mm-hmm. The second thing is look at sometimes the variability between the same procedure can be over 3,000%. I studied a state health plan with 139,000 employees, 280,000 individuals once you included their spouses. The billed charges, this was going back a few years ago, was $2.7 billion. Okay. The paid claims, $1.6 billion. Within one procedure, CT scan of the abdomen with and without contrast, the median cost was $635. The high, you'll never guess it, $19,800 for CT scan.
Wait. Yeah, we've all heard the stories, about how if you go in and you don't have insurance, but you say I'll pay for it, they're going to charge you a whole lot more than they would charge you, your insurance company. But I wouldn't expect that would be true within an insurance company.
Oh, yeah. Within the same insurance company network, sometimes in the same city, it can be 1,000% variance 2 miles away. Colonoscopy, the average was 1,212. High was 17,341. That's 1,100% from the average to the high, not the low to the high, the average to the high. Now, most procurement people in companies, let's say the guy that's in charge of buying coffee beans for Starbucks, okay? Mm-hmm. There could be a fire in a coffee growing country that increases the price of coffee, so then he has to shift where he buys, okay? Right. Things like that happen, that's fine. Most procurement people have a tolerance above the average that they will pay, okay? And that's usually not 1,000%.
I was going to say, no, it's like single digits.
Exactly.
But, sometimes double digits, but usually
exactly.
Single digit.
Yeah. But within healthcare, it's triple digits. Okay. It's triple digits. And, a self-insured employer owns their own data. Okay. You have a right as an employer to examine your claims data to see how much are paying in claims, okay? To see how much hospital A was paid, how much hospital B was paid. Now, another thing is, were they actually paid? Or did the insurance company just take that out of your account? There's one lawsuit on spread pricing where they paid a hospital evidently $800 and something thousand, but they charged the employer over $2 million. Okay, so it's really, really important to examine that data. There's so much information in there, so many changes that you can make just looking at that. So those are the first two. Those are just two things: the contract and the data.
My mind is boggled. So I'm sitting here going, wait. This is staggering, and I'm wondering, what, if anything, can be done to rectify that? I mean, are there any changes that we could enact that would fix that problem, or is this just a reality of the system?
Well, it is a current reality.
Okay.
Let's put it that way. It doesn't have to be. There have been transparency acts and legislations passed over the years. Mm-hmm. Well-meaning, but impact was relatively low. Okay. And don't get me wrong. Transparency is mandatory. It's essential. You need it. Okay. But transparency alone If you had a plan with a certain amount of deductibles, copays, et cetera, and you did one thing and one thing only, and you said, I'm going to add transparency, that would probably increase your costs, Bill. Okay. And here's why. Here's why.
Please explain.
So let's say you've got the average person earning, let's say 60 grand a year that needs a knee replacement. Okay.
Okay.
His deductible is 5,000. His out of pocket, our expenses are maximum, let's say 7,000. Okay. So unless you go to India, anywhere in the world, a knee replacement is going to be over $7,000. Okay. Anywhere in America, it's going to be far above that. So if that person has transparency and they look at two different providers, one of them has charges of $90,000, one has charges of $30,000. And he's told, look, you're out of pocket maximum $7 grand. You go at either one, it's going to be the same. Okay. He doesn't care. I don't say that callously. But he doesn't feel like it has impact. And a lot of times he'll say, well, the guy that wants 90,000, he's got to be better. Okay.
Right.
As a matter of fact, usually the exact opposite is true. Okay. Because skilled surgeons and doctors go in and out much quicker, less OR time, less nights in the hospital, less anesthesia time. So it actually often costs less to have a better doctor and a better hospital do the procedure. So transparency alone is definitely not the answer.
Well, then what could we add to transparency that would make a difference?
Well, number one, the contracting language, where the insurance administrator is only allowed to pay out so much. Okay, they can't pay $19,800 for a colonoscopy. Okay, so that's one thing. That's contract language. But the other thing is where you, as an employer, when you look at that data, when you analyze your claims, you say, okay, if anybody notices that hospital A on average has the same or better outcomes, but much lower prices, let's give an incentive if people go there. Okay. Some employers even take it a little bit further with medical tourism, where you might get an incentive to travel to Phoenix or to Mexico or to India to get that medical care. So offering an incentive. So transparency alone, when it's going to cost you the same, will have often an adverse effect. Okay. Transparency with an incentive will have a better effect.
Yeah. No, that makes a ton of sense. Well, I'm sitting here listening to this and I'm thinking, it's incredibly complicated and it's a lot of data that to juggle and to analyze. And I'm now beginning to get a sense of how your previous career of air traffic controller becomes beneficial in this whole process.
It does. Air traffic control, you could have 50 or more aircraft in your control. They could have speeds varying from 80 miles an hour to 500-600 or even more. You could have altitudes ranging from 0 to 18,000 feet, from 18 to 45,000 feet. You have airplanes going different directions, different speeds. They're climbing, they're descending, they're going different directions. You have wind coming this way, coming that way at different altitudes. It comes from a different direction. The planes are in clouds. It's night. They're flying blind. Your job as an air traffic controller is to keep all of those aircraft apart, keep them safe, get them to their destination safely. What I do right now is very similar, Bill. It's very similar. Every client is different. Some of them are two-seater passengers going 120 knots. Some of them are 500 passengers going 560 knots. And I have to make sure that I keep them en route to their destination, that I give them a flight plan that they can follow from point to point to point. I allow them to climb to avoid some weather. Sometimes I allow them to descend to avoid some traffic, and it's very similar. That's the amount of coordination to really manage a plan well. Now, the other thing about the numbers, I talked about 5 trillion, and I can get even deeper into that, what that means. But most employers, their healthcare costs are their number 2 line item after payroll.
Yeah.
Starbucks spends more on healthcare than they do on coffee beans. General Motors spends more on healthcare than they do on sheet metal. Okay. It's that huge. Most companies have a CEO and a CFO, but the health plan is often a business within that business. And that health plan doesn't have its own CEO or CFO for that matter. So that's what we like to do. We like to get in there and really run that health plan like the business within the business that it really is.
So you become the CFO, basically, of the insurance plan.
Absolutely.
Wow. That's an incredible task. It's frankly, from where I sit, a kind of overwhelming task.
It is.
So, I mean, what keeps you motivated? I mean, how do you, I could see you losing your passion in the complication, if you will.
Yeah. It is complicated, Bill. So is air traffic control. So is anything worth doing, and with anything worth doing, there's always an easy path and a hard path. Mm-hmm. And often we take the hard path, not because it's hard, but because often it's the right thing to do. Okay. Now, there are times that the employer says, hey, just give me a break for a bit. Let me press the easy button just this 1 year. Let me just glide through this. There's been too much turmoil. Fine. Cool. No problem. I get it. Let's take the easy path for a little while, and then let's really build something better.
That's interesting. I mean, when I think of my experience with healthcare plans in the workplace, they've usually remained pretty consistent. I mean, granted, at one point I worked for a company where every year you had the options to look at your plan and decide you were going to go with a higher deductible or lower deductible. You could shift around in terms of your choices and stuff. And it sounds like that's kind of what you're saying, is that, you offer employers an opportunity to do that.
Yeah. I come across a lot of employers that have a plan that's a sealed capsule. You can't look inside it. You can't see what's broken. You can't see why is it so expensive. Okay. Only if you can take it apart can you really look at it and analyze it. So switching from one carrier to another, I've seen a lot of employers do that year after year, thinking, well, this didn't work. Let's try a different insurance company. Maybe it'll be better. Well, this didn't work. Let's try something else. And they're just chasing an impossible goal. And they might get a little bit of a break just for moving because the other carrier wants to buy their business. But getting in there and really analyzing the needs and the problems and what some of the obstacles are is really important. And talking to the employees too, instead of saying, hey, here's 5 plans. For example, often the HSA plan, health savings account, can be a better plan if the employer contributes a little bit towards the HSA, because what you pay in premium plus what you get in HSA contributions plus your maximum deductible can be less than the option, sometimes not. So it's really getting that explanation. Some human resources department just put it out there and say, here you go, here's the choices, here's the numbers, and they do very little. I think employees need that help, that helping hand, that analysis where they have these plans really described to them.
So I'm curious, what is your vision for the future of healthcare in the workplace, Ralph? Where do you see this going?
Have you seen Star Trek? It's very simple. They bring that scanner. They don't have to do surgery.
Yeah, sure.
There's a new Star Trek coming out this year, though. Yeah, sorry, I'm a bit of a Trekkie. There's a new Star Trek coming out. That's why that came to mind. No, I mean, there's no question that the U.S. has some of the best technology, some of the best doctors.
Yeah,
but we don't have a gridlock on it. There's great healthcare all over the world. Single payer is not the solution. That comes with rationing and wait times. If it's two-tier, it's a little bit better than single payer, true single payer, which only 3 countries in the world have. I think it's many things. For example, I've heard that the cost of paying a medical bill for the insurance company and the provider, whether that's a hospital or a doctor, between them, the total cost can easily add up to 30%, but conservatively 20%. Okay. So 20% of $5.1 trillion is $1 trillion. And that's real money. That's just the payment.
It's real money in my world.
Yeah.
That's just for the payment.
That's just for making the payment. Sending the bill, making the invoice, sending it to the insurance company, going back and forth, having it discounted, having it approved, collecting the employee's portion. There's so many tentacles.
It's over $1 trillion just in the process.
Yep.
Wow. Well, then that kind of begs the question, if you could change one thing about the healthcare finance and the healthcare system, what would it be?
There isn't just one thing, Bill. The payment system is one of them.
I was hoping there'd be one thing. I didn't think there would be.
No. That's an easy one. That's like, knock off 20% by fixing that. Okay. But it's not that easy. There's also what does the employee pay? And, for example, if you have a plan where some things are free, or very, very low cost in terms of what you have to pay at the time that you consume it, your costs are very low. For example, since the ACA passed preventive care, there are 78 items that have to be covered at no cost to you, like an annual physical, pap smear, mammogram, colonoscopy, those kinds of things, preventive care things. Okay.
Yeah.
Now, in a traditional plan that has an annual deductible and out-of-pocket cost, sometimes when that employee gets to the point where they've used up their whole deductible, they overconsume. Okay. They say, hey, listen, our deductible's all used up. What can we get done? What do we need done? Right. And now there's argument, like, for example, let's have these suspicious moles looked at. Is that overconsumption? Is it something they wouldn't do if they had a whole deductible? Maybe it is something. However, they might catch melanoma before it becomes stage 3. Okay. So that is an essential health service that could save money. If you make it too expensive, they won't have it done. And then they're diagnosed with something much more serious. So, it is really, really complicated. It requires a lot of work. If it was easy to fix, you would think it would have been fixed a long time ago. We move a little bit at a time. We every day it's better than the day before.
Well, what's really frustrating, just as just from where I sit, I'm going to call myself the outsider and you the insider because you've got a much better view of these things. But I look around and I see state healthcare systems, meaning government healthcare systems, on the brink of bankruptcy, reducing services, running out of money. And so I see huge problems with government-run healthcare services.
Yes,
you can see that in Canada, you can see that in London and England now. And then I look at the United States and I look at the enormous cost that we endure and have to pay for our healthcare system, and I'm just confounded. And I'm wondering if you can give us any insight as to where we should be looking or what kind of path maybe we should be thinking about for the future.
Here's an interesting fact. The pharmacy industry spends more money on marketing than they do on research and development. Okay?
Doesn't surprise me.
No, it doesn't surprise me either. But, what value? They increase their sales. Okay? That's the value to them as a business. Okay? Right. And most businesses, should want to increase their sales and grow. But by selling more drugs, if they're needed, yes, absolutely. Cost of drugs, the rebates, the kickbacks, that's one area that we need to look at. Some transparency in the pharmacy industry, because there's big lack of transparency there. That's one area. The variability within any insurance network, that's a huge area. The cost of making a payment. So I think those are probably three of the big ones that could probably cut your costs by 40, 50%.
Wow.
If they are completely fixed.
Wow, that's interesting. Well, we're getting ready to close this one out, so I'm going to throw you a curveball on this one, and that is, what advice would you give someone who's listening to this podcast who might be interested in, going into the healthcare and finance career?
Interesting. Well, I think that if you are doing it for the right reasons, if you have a passion, if you understand the finance, and there's two ways to look. I had a registered nurse that worked for me at one time, and she was great. Medically, she cared for patients and she prioritized like a nurse would. She triaged. Okay. However, it ended up being sort of a bit of a conflict because she increased the employer's costs, because she got, some of the things prioritized that made sense medically. Okay. So it's a good background to have, but you have to know the rest of the picture. You have to know how the pieces fit so that you can put it together properly. If you do have somewhat of a medical background or understanding, that's great. That's helpful, but you have to have the finance understanding and background as well. A lot of people that put together group health plans, they'll do one per year. Okay. So they're not experts. They do it because they have a friend, they have a connection. They're sometimes they get lucky and they do the right thing, but sometimes they don't. So study, learn the material, learn what you're doing, focus, specialize, and become really good at it.
So they don't have to be an air traffic controller first, right?
It helps. It helps. It absolutely
I can see
helps.
how it does. I can see how it would, as a matter of fact. So, Ralph, anybody who's listening to this podcast today who is intrigued and thinking that they would like to reach out to you and talk with you and see if maybe you could help them out, how would they get a hold of you? What's the best way to contact you?
Well, there's two ways. Send me an email, ralph@thebenefitwhisperer.com, or call me at 832-924-3330.
Terrific. That's outstanding. The other thing you can do if you're listening to this podcast and you're not a subscriber yet is hit the follow button.
Absolutely.
Become a subscriber. That way, every time a new episode is dropped, you're notified. You can give it a listen. There it is.
And share the podcast.
Well, yes, absolutely share it. Because if you find this information interesting, helpful, useful, or if you know somebody who might find it interesting and helpful and useful, let them know about it, please.
Absolutely.
Word of mouth promotion is outstanding, and it just can't be beat in terms of recommendations and a tool for promotion.
Absolutely.
So until next time, I'm Bill Tucker on behalf of Ralph and everybody at the Benefit Whisperer. Thank you for taking the time to listen today. We appreciate it. And just remember, you can go out today and make today a great day or not. The choice is yours. Until next time.
Thank you for listening to the Benefit Whisperer podcast. Click the follow button to be notified when new episodes become available. Looking to reach out? Visit our website at www.thebenefitwhisperer.com or give us a call at 832-924-3330. And don't forget to click the follow button to be notified when new episodes become available. The information covered and posted represents the views and opinions of the guest and does not necessarily represent the views or opinions of the Benefit Whisperer. The content has been made available for informational and educational purposes only. The content is not intended to be used as a substitute for professional investing advice. Always seek the advice of your financial advisor or other qualified financial service provider with any questions you may have regarding your investment planning.